I really thought, do you need to start now? Actually, you can start now. No, no problem. You can start now. So I thought that I have you at 1 p.m. and that I finished the girls' lecture at 12. So I went back to my office. This is why it took me a while to come back. Subhanallah azim. And I told myself, okay, I will not be late for the guys' lecture at least today. Obviously not. You know. All right. So let's talk about disorders of the prostate. Cannot bring this in, right? You cannot. Another malfunction. Okay, so we did talk about it before. If you guys still recall, POD, which is very far in the past. So we did talk about the two actually components of the prostate, the stromal and the epithelial, elements of the prostate. And here we are going to touch upon inflammation, hyperplasia, and cancer. So this is actually the two components of the prostate: the fibromuscular stroma and the epithelial component. The stromal cells have an enzyme known as 5-alpha reductase, which actually works on the circulating testosterone to convert it into dihydrotestosterone, the most powerful androgen that is around. And DHA is at the core heart of all the problems that happen in the prostate, whether it is actually, MPH, nodular prostatic hyperplasia, or cancer. You can relate them back to androgen. And to treat, as you can see, there is a lot. I'm sure Dr. Danny mentioned this to you. There's a lot about hormonal treatment that could be, given to those patients who suffer from, from the two conditions. So this is actually with regard to the stroma, a clinically, important fact about the stromal cells. Now, regarding actually the glandular cells, I don't think that Dr. Danny mentioned this to you. Let's see if he did. Okay, so the glandular cells are actually, the glands are surrounded by two layers of cells. There is the columnar cells, which secrete what? PSA, right? The prostatic specific antigen. Okay, and the second cell layer is the basal cell layer. Okay, how would you differentiate between the two? They are perpendicular on each other, right? Can you see that? So this is the columnar cell, and this is the cuboidal, basal cell layer. Now, your mission as a pathologist is to ensure that the glands you're looking at are surrounded with this basal cell layer. If the glands are missing the basal cell layer, then immediately you have moved into dysplastic features. Okay. A lot of times, you will see as a result of the cut, a gland is going to be actually missing a portion of its basal cell layer as a result, of it being cut, the gland being cut tangentially. How does a gland look like in normal in 3D structure? What is a gland in a 3D structure? Is it a circle? What is it then? A ball, right? It's a ball of cell, isn't it? It's really a ball. So depending on how you cut it, you may end up actually with, like, what do you call it, an oblique kind of cut where you're not going to be able to see the basal cell layer. So what to do? To actually, you need three glands that fulfill, architectural and cytologic criteria to call it prostatic adenocarcinoma. Okay? So, a lot of times, actually, you will see that two glands will fulfill these criteria, especially the basal cell layer, but not the third gland. So now, thankfully, molecular pathology has come to the forefront. And instead, actually, of doing all this indirect kind of conformation of the glands by actually either doing deeper cuts on the glands to make sure that you may reach a point where you will see the full circle that is the gland on your histologic section, or to do actually what you call low molecular weight keratin, the cytokeratin 903, which highlights the basal cell layer. Okay. Now there are actually more immunohistochemical stain that will stay in the malignant cells itself. One of them that came actually out of this is called Amalcar, and that actually stains the prostatic cancer cell itself. So that's what you call a direct kind of investigation of cancer cells. Okay, It used to be like the last case I signed out when I was training was actually a prostatic adenocarcinoma cases, believe it or not. And it was, a 3 glands that looks like, they are malignant glands. They were infiltrative. 2 of them were actually having missed the basal cell layer, and we did the cytokeratin 903 on them, and it turned out to be negative. But the third one was actually was like 50-50. You can see that it is missing some, but not the rest. So what would you do? We did deeper cut. After deeper cut, the tissue itself was done. There was no more tissue to cut. So you have lost the tissue. And then 2 years into my fellowship, actually in Canada, I actually was reading about the Amalcar, the new stain on the block that now stains the prostatic adenocarcinoma cell. So this is just, to make a point to you that you will get stuff on pathology that you will not get in clinical medicine, just, between you and me. All right, now prostatitis. Now, as opposed to a lot of other organs, you will see that the acute form of the disease is in the minority, up to around 5%. Even the chronic form of the disease, the chronic bacterial form of the disease, is really also a small minority, about 5%, another 5%. The majority of cases will be the cases that will make you scratch your head. What is happening in this patient? Because your patient will come in with all the signs and symptoms, all the bells and whistles of prostatitis. He's going to be having low back pain, dysuria, pain in the groin that goes to that will be felt in the scrotum, in the testes, or that could be felt actually on the medial side of the thigh, and that could be felt even like in the anal canal, with a suprapubic discomfort. You do that test, you do the testing, and nothing will come back positive. So you do the urinalysis, and you do the culture, and nothing will come back positive. You do massage, actually the patient is coming in with a chronic prostatitis, or chronic disease. That is, you may do massage to the prostate to actually express those secretions. You may take these secretions and send them to the gram stain and to the culture lab. You may even do PCR on them. Everything will be negative. So you're left with something that used to be up in the air for a long time. Now we have a name for it. It's called chronic pelvic pain syndrome, the CPPS. The vast majority of cases of chronic pelvic pain syndrome in males is caused by prostatitis. Not all the cases, but the majority of them. Now, the same, if you are interested, the same kind of entity is present also in females. Chronic pelvic pain syndrome. We talked about it last week. What was it? Excellent. Interstitial cystitis, Hunner's ulcer. The Hunner ulcer may give the patient similar pain, that will be under the umbrella of chronic pelvic pain, with negative, if you recall, negative kind of findings. Everything is negative, right? And then you have the autoimmune basis of it that is going to clue you that this is maybe autoimmune related. You ask the patient further, and they will tell you, we have this or that autoimmune disease, most commonly SLE, systemic lupus erythematosus. Okay, another cause for it in females is going to be endometriosis, or even pelvic inflammatory disease, PID. All right, now coming back to males, in 90 to 95% of the time, that's actually is going to be the CPPS, the chronic non-bacterial prostatitis. It's a diagnosis of exclusion, not because it is rare, but because it's a difficult disease, and because it's much easier actually to diagnose acute prostatitis, right, and chronic bacterial prostatitis than to diagnose the chronic non-bacterial prostatitis. That's one. Two, it is really an enigma, because in this disease, you will see that there is a coalescence. Usually it's not one that comes to man and beat him, right? It's usually multiple factor. He married like a very annoying wife recently. That is a very important factor to wreck his life, right? And then you have some hormonal imbalances. Maybe his boss is not happy with him, so you throw in a little bit stress and discomfort, if you want to call it, right? And then some mental disorders, believe it or not. So at the end of the day, it's what you call a multifactorial disease. So that may result actually in the development of the chronic non-bacterial prostatitis, the CPPS. And to address it, actually, also you have to go like in a multiple, kind of approach, as you will see. I'm learning actually my way around ChatGPT. I added a very nice part for you in the legend of this CVBS. Please read it. Makes for an incredible reading. This ChatGPT can get away with a lot of things. One of them is copyrights. A question for you, not to answer now, but after the lecture. How do they get away with copyrights? Because what they put in has come from somewhere, but there is absolutely no credit to what they give you. Okay? So they gave me a piece, none, not even up to date will give you this kind of piece. Very succinct, very direct, and very on target, absolutely on target, but with absolutely no references. How do they get along? How did they get away with this? I want to know. If you know, let me know, please. All right, so coming back to acute prostatitis. So in this case, your patient, from history, it is the first episode, okay, of this disease coming in with this kind of presentation. Usually what you call a stark kind of presentation. Someone was doing, fine, and then all of a sudden wake up with this kind of presentation. Now, in terms of, its cause, it's going to be, again, going back to this, 30 to 40 kind of cut, where, below it, you will see the STDs, such as chlamydia and gonorrhea. Above it, you will see the GI, right? This is what happened usually in life too. When someone is young, he's more interested in the STD kind of stuff. As they go, and if you know what I mean, as they go higher in life, at more advanced in life, they start to be more interested in food, right? SubhanAllah, it is exactly the case. Now, one advice for you, do not, at least this is what they advise. A lot of places, especially American medicine is known for its adventurism, right? It's a pretty adventurous, medicine. It is a research-based medicine, as opposed to what you see medicine in the other countries, such as the UK and other countries. So they usually do DRA in the US. Now they do it with a lot of care. Why? Because first, it is exquisitely painful to the patient, okay? You don't want your patient to be cursing you. This is number one. Number two, actually, there is also a problem of manipulating a gland that is full of pathogen, because you may be releasing it in the blood. Where else do you see in medicine an advice not to fiddle with one tissue? For the physician, and sometimes first for the surgeon, and sometimes for the physician and his patient. For the surgeon, where do they tell you during surgery, don't play with this? What did you say? Pancreas? No, not pancreas. Spleen? No. What's in the spleen? You have to ask yourself, what's in the spleen? What's in that organ? No, there's nothing in lymph nodes. Adrenal glands, especially adrenal glands, only, not especially, only adrenal glands affected by pheochromocytoma. Have you heard about pheochromocytoma? I'm sure you did. You have, endorrhea under your belt. So pheochromocytoma, this actually tumor is filled with prepackaged, right, epinephrine. You play with it a little bit, what will happen to this good stuff? Will be released into what you may kill the patient on the operating table, because he will have, an episode. It's an episodic hypertension, right? So an episode of hypertension from which the recovery is absolutely zero. This is one. Two, what is the second, organ or structure they tell you not to fiddle with? Because again, of the same thing, especially if you have the hyper, disorder of that tissue, the thyroid. You play with the thyroid in a patient with hyperthyroidism, you may put him into what? Thyroid storm, exactly. Also, these prepackaged hormones are there, that may actually be released, and that's gonna wreak havoc on the patient, So be careful. You're there not to play with things, but just to examine and have a diagnosis, right? So now coming to chronic non-bacterial prostatitis. Once you hear about the survey that the patient is going to be filling, you know that it's not an easy diagnosis. Where else did you hear about a survey that a patient has to be filled in the MSI block? Fibromyalgia, absolutely. SLE, I'm not so sure, because you do have some clues to clue you in SLE. But you also rheumatoid arthritis, actually, believe it or not. Those difficult diseases, because of their difficulty in diagnosis, you will see that your patient is going to actually be filling a survey. That's what you call subjective symptoms. And then there are the objective symptoms that you will be elicit on examination and investigation, okay? So that tells you, right, once you see a survey, you know that this is not really an easy disease to to diagnose and then to eventually manage. So they need to fill in an NIH symptom index. One, then you have to do as the treating clinician, DRE, urinalysis, and sequential collection of secretions, as a result of actually massaging the prostate. Remember, this is a chronic prostatitis, so it is okay to actually do the massage on the prostatitis in those patients. And you're doing all of this in order to ensure that there is no pathogen that the patient is developing, that the patient has that developed this condition, that is chronic non-bacterial prostatitis. So there is this legend that I added. Please read it and let me know how does ChatGPT and the new kids on the block get away with copyrights. Okay, this is it. So in this case, you will see that there is what we call multiple kind of dysregulation. Now here is a scenario for you: a chronic bacterial an acute prostatitis that was not treated enough, or was not treated adequately, or was treated with the wrong kind of medication. Now remember that this is a fibromuscular glandular organ, right? And now for antibiotic to penetrate it, it needs the right antibiotic and for a good period of time. What did Dr. Rabah tell you about the time line for treating prostatitis? Did he mention anything about that? Did he give you prostatitis? Yes, tumors. So he did not give you prostatitis last week. Who gave you prostatitis other than me? Really? Well, I think that this is definitely another gap that needs to be filled. Okay, so imagine this, chronic chronic bacterial prostatitis that developed as a result of inadequate treatment, incorrect treatment, whatever you want to call it. Eventually, the patient is also under a lot of stress from his house, right? As I mentioned to you, from his job, as I mentioned to you as well. Okay, and you add to it a little bit of like innate kind of disruption of the immune system, and the result is going to be the result is going to be this kind of presentation. That is what is known as actually as neurogenic inflammation. Neurogenic inflammation. This is the new kids on the block. When it comes to neural disorders, some of your colleagues who are in the US are actually specializing in this kind of presentation, with this kind of diseases, actually this kind or this subset of diseases that are related to immunity and autoimmunity. So again, the approach to it is going to be in kind. You do not actually treat just with like with antibiotic. They attempt to treat it with antibiotic and with other stuff as well, muscle relaxant to relax actually the muscles of the pelvic floor. They may actually even treat any kind of depression. So psychiatrists may be involved, in the presentation. Neurologists may be involved also in the presentation. In terms of treating, it's going to be as hard as diagnosing it. It's going to be a hard disease to treat as well. It does not happen overnight. It happens over a prolonged period of time as a result of these factors coming in and playing, interplaying with each other. Now, another actually, scenario, for example, let's say that someone who's coming in with all the signs and symptoms of chronic prostatitis. In a lot of places, unfortunately, around the world, it's a knee-jerk reaction to do PSA. You found that the PSA is elevated. Do you have to do, here's the question, do you have to do a biopsy? The answer to that is absolutely yes. Because if you don't do, your patient can sue you easily and could win. Because PSA is known, especially in those categories when it goes way above 10 nanogram per milliliter, that it's going to be in the malignant category. Does prostatitis cause elevation of the PSA? The answer to that is absolutely yes. Okay, but not in the way that cancer could do it. Cancer has this ability to produce enormous amounts of anything really, including PSA. So for the majority, the reason why I mentioned this to you, it's a disclaimer. For the majority of cases of prostatitis, 99% of the time, you don't do a biopsy, okay? There is only one kind of prostatitis that is going to warrant biopsy, and that is going to be granulomatous prostatitis. Now the question, that should come to your mind, where did the granulomatous prostatitis come to the prostate? And that is related to the instillation of BCG into the urinary bladder. Did he mention this to you? Okay, good. What will it cause in the urinary bladder wall? And why would you call it? Why are you crazy to put in BCG, the inactivated, the inactivated vaccine, right? For TB that used to be given into the bladder wall. Why are you doing this? To go after what? To go after urothelial carcinoma, absolutely. So you instill it because it has been shown that this granulomatous reaction that is going to be happening in the urothelial wall, in the urinary bladder wall, is going to destroy the urothelial carcinoma. Okay, it is really what you call hacking the immune system to to gear it towards treatment of urothelial carcinoma. It was attempted with other tumors with less success actually than the urothelial carcinoma. In the process of doing this, actually, that it was shown that it may also result because of the direct relationship of the prostate with the urinary bladder. They sit on the urinary bladder sits on top of it, right? So that actually may result in granulomatous inflammation in the urinary in the prostate as well. Okay, so that's when the only reason why you need to actually do a biopsy on the prostate. Now, BCG is really an enigma. It has been shown that nowadays, actually, a new study that came out of the UK, that BCG, those who have received BCG have less, likelihood of developing strokes and developing, myocardial infarction. How about that? And recently, we have also seen the BCG in the COVID-19. What was it said about the COVID-19 and BCG? Do you guys know? Wow. Where did you know that? Wow. Excellent, man. Well, at least, there's what you call what do you call it? They call it a shimmer of hope, a shimmer of light of hope, in our student that there is something called scientific curiosity. Medicine did not manage to kill all of it. They will put a target, they will put a bullseye on your back for sure. This is incredible. Very good, man. This is like also the girls have one who answered the question, and I was as amazed as with your answer now. Absolutely. It was shown actually that BCG, those who have received BCG are less likely to get infected with COVID-19. How about that? And that if they got the COVID-19, it was less likely to be severe. It was more likely to be actually mild and weak kind of infection as opposed to those who did not receive it. So a pretty magic, drug, if you ask me. I'm thinking about getting a shot myself, believe it or not. That would be a nice, actually, a preemptive strike, right? So now if you look, this is, if you want to take a look at what an acute prostatitis will look like, it will look like this. This is a patient who succumbed, for other reasons, irrelevant reasons, to prostatitis. But it may actually be related. How could someone with acute prostatitis die? If it's a cause, sepsis, exactly. If it reached the blood and then as it was untreated or mistreated in the prostate, it was also mistreated as a septic case, and that may actually send the patient into the next life. But in this case, actually, you will see a lot of goo. This greenish goo. What is this? This is pus, which is neutrophils, right? This is the newts. All right, now we talk about nodular prostatic hyperplasia. Now, in a lot of places, you will start to read now that some, or not a lot of places, I would say 50-50 maybe, you will see places that will tell you that this is not really a disease and that this is part of normal development. When something is happening at a 90% rate in later, like in advanced life, you have to wonder, what is really happening in those patients. Another thing, actually, that only 10% of those patients who have the condition develop the symptoms. So that tells you that it is not in only symptomatic, it's only symptomatic in the minority of cases. So, let's say 10% at 40, or maybe 5 to 10% at 40, 90% by 80 years of age. So everybody is going to get it at one point in time. Now, this prostate at 40 is the size of walnut. As the patient is, aging, what happened to this prostate? Gonna get larger and larger and larger, and then at 80, what will it be? size of small apple, actually, believe it or not. A question will be, one of the questions that I had when I was receiving all this prostate during my training, how could someone sit on something like this? It's huge. Obviously, it's not growing this overnight. It is growing, gradually, and the person is able to accommodate it as they grow. Now, here's another question for you. PSA is being secreted from this prostate when it is a walnut size, right? Size. Now, let's say that it is that's 2 factor, okay? When it is actually the size of an apple, how much will be secreted from it? Probably 10, right? So it will quadruple, right? It will be a lot more than that. This is something to keep in mind. So PSA is related to age. Remember that for the next few slides. What is the basis for the MPH? Everything goes back when it comes to the prostate. If you say androgen, you're going to be right. You're going to be absolutely right. So it is the androgen, right? This very powerful hormone that succumbs every time it meets the estrogen in real life, whether figuratively or actually in real life, if you know what I mean. All right, so we have evidence to the fact that actually that was a joke. Thank you very much. At least you smiled to it. All right, so we have an evidence to this actually mechanism, a real life evidence, clinical evidence that is, and that is castrated men don't develop. This is one of the the perks of being castrated. They don't develop MPH or prostate cancer. How about that? And then another thing actually is that those men with androgen with males with androgen insensitivity syndromes also do not develop this condition and do not develop prostatic adenocarcinoma, to show you that it is related to androgen. Now someone will say, I'll come and tell you, as you will see in the next slide, just before we talk about that. Okay, so everything is related to DHT. At the end of the day, it is androgen-dependent tumor. Remember that. Similar to what we see in estrogen-dependent tumor. What are the estrogen-dependent tumors? And not in cervical, endometrial. Okay. Now, why is it more likely for a female to get those estrogen-dependent tumors than male than those who are not obese? Why is it? Fat estrogen. I never heard it like this before. It's not fat estrogen, it's peripheral conversion, right? So peripheral conversion of androgen into estrogen, you have an added thing actually here. So here is a question for you. So also obesity is related. Are you okay? Any accident? It's a good morning. So we want to see that. Okay. So, again, like obesity is also related to prostatic adenocarcinoma. You will tell me tomorrow, how is that happening? So you know how the conversion is happening in females. Androgen are converted into estrogen. So you have added estrogen that will affect all these organs that respond to estrogen, developing tumor. How does that happen in males? Please let me know tomorrow from you. And then I promise you I'll take it easy on you in the exam. Okay? If I can. I don't know if they allow me to do that. And of course, in the SAQ, usually and believe it or not, we actually take it on you very easy in the SAQ, At least I can talk about myself. If you say it's a 5-word kind of an answer, and you say 2 or 3, you get the full mark. If you say 1, you get probably, 3/4 of the mark. And especially for year 3, because you guys have been filtered enough. I feel sorry when I look at a diminished class. So, I guess it's more of, breaking the heart of the correctors, This is a joke, of course, Don't take everything I say seriously, especially that I am pretty upset this morning. All right, so clinical manifestation, only in about 10% of males with the histologic evidence of MPH that they go actually to develop symptoms of the disease. Now, where does it happen actually in the prostate? It happens in the area around the prostate, the urethra, what you call the prostatic urethra region. So as a result of that, the symptoms that the patients will get is usually that of an obstructive symptoms, okay? All right, so as a result of that, they have a problem initiating the urinary stream. So you would tell if someone is having MPH by the time they spend in the restroom, actually, believe it or not. The longer they spend in the restroom, the more that they have a problem actually first initiating the stream to emptying completely the bladder. Emptying the bladder does not happen. Why? Because the first part of the stream will be powerful enough to keep the prostatic urethra open. But then as it diminishes in the bladder, this stream becomes weaker and weaker, and as a result of that, with so much tissue, it will collapse. As a result of that, dribbling will start to happen in those patients. Interruption and dribbling. And that, the volume will not completely be cleared from the urinary bladder. And as a result of that, they will start actually to feel urgency to come back and, go out again because they did not empty the bladder the first time. So all symptoms related to urinary obstruction, okay? As you have seen it, and you will see it now, it's pretty, nodular. This nodular, usually white, woolly nodule when it's cut. You will see that with your naked eye, okay? With no yellow color. Yellow color is bad in the prostate because yellow color is the color of fat. And it is known actually that, the structure that will have fat in the prostate is going to be prostatic cancer. Those prostatic cancer, when you look under the microscope, they will have cytoplasmic clearing because their cytoplasm are filled with fat, okay? Also because of the urinary, like obstruction that those patients are having, they are actually prone to develop stones, as a result of the stasis that happen in the prostate and infection as well. And I remember that the urinary bladder now is actually contracting against a high pressure gradient in the form of the prostate, hypertrophied prostate. As a result of that, those fibers will hypertrophy, resulting in trabeculation. We talked about trabeculation and the acquired diverticula that may happen through the trabeculation, as we have talked about before. Now, how would you release it? If you look at this, so one way to do it is to come inside and start to scrape, right? Start to scrape. That's what is known as transurethral resection of the prostate. It's one heck of an operation. It's a very bloody operation, very painful operation, and it's pretty tough for the surgeon, pretty tough for the patient, okay, and very tough for the pathologist. The pathologist, believe it or not, it's a nightmare when they see this. They send it to you in a small jar, about like, let's say maybe 60, 70 kind of, chips of the prostate. You need to go through each one of them to ensure that none have cancer, because the two diagnoses go hand in hand. They mirror itself, they mirror each other in age. They mirror each other in mechanism, pathology mechanism. So you have to actually document, what is present there in these chips. So if you take a section of this, you will see the nodules, that we have talked about now on microscopic level. Now you will see that the nodules are minding its own business. Nothing is leaving the nodule and spreading to nearby nodule. So infiltration or invasion is not there. So this is architecture, speaking for medical school, it is actually completely benign. Now you go on higher power and you start to see that all these glands, have a double cell layer. So those glands are benign. You look at the individual cells and you will see a lot of cytoplasm. And you look at this cytoplasm and it does not look clear to me. Does it look clear to you? It does not look clear. The NC ratio is pretty low, and then you will see that, there is not much really of a piling, and there is a good amount of actually stratification because those layers on the surface, have very small nuclei. So that's exactly what you expect. Actually, how about this here? Also, what you expect in a normally mature epithelium. All right, sorry about that. Is this good? Okay, good. So if you look at the maturation, it's pretty good. The cells on the top are not really, atypical in any way, shape, or form, as opposed to what you will see in the next slides. All right, so now we are talking about prostatic adenocarcinoma. It's going to mirror the NPH in many ways. Okay, it's going to mirror it in age. So it usually happens, starts to happen at a higher frequency in older age. One. Two, in terms of mechanism as well. Both of them are androgen dependent. Now, if you look at this prostate here, you will see, that a carcinoma of the prostate, rather than arising in the periurethral region, it's arising in the peripheral posterior region. So as a result of that, it rarely presents with obstructive symptoms. And when it presents with obstructive symptoms, we're talking about the majority of cases, the disease does not read the book, so the prostatic adenocarcinoma could really arise from anywhere, right? But we are talking, most common things happen most commonly. Most commonly, it will arise from the posterior peripheral aspect of the prostate. In this prostate, for it to cause obstruction, it should have gone and invaded other parts of the prostate, which means that it will happen in this case, but in advanced cases. So you will see that, obstructive symptoms associated with, prostatic adenocarcinoma denote an advanced disease. Okay. Now that's an enigmatic kind of disease as well. The reason for this is that a lot of patients die with the disease rather than of the disease, to the point that actually it creates an enigma. What to do about those tumors that are small enough and that they mind their business enough not to warrant any kind of treatment. As a result of that, a lot of places around the world do not advise to do PSA, because the minute you do a PSA, you open a Pandora box. The minute you find that the PSA has increased, what to do next? You have to biopsy. And if you see a tumor, what to do next? Surgery. What could actually decide if the tumor is, if in that category or in this category? Is it one of those tumors that are lethal, which are the minority, of patients, where it's going to actually, spread like wildfire and kill the patient in no time? Or is it the other kind that will mind its own business and the patient will live well for a while, very likely to die of other causes irrelevant to prostatic adenocarcinoma? To this day, we don't have really a biomarker that is going to tell us the difference between the two. Okay, that's going to be on your chip, on your shoulders, to actually come up with something like this, to find out anything that can help in the differentiation between the two categories. Okay, so many more die with the disease, as opposed, with, of the disease. Now, another thing actually is that it is a disease that is classic in other ways. So it is known to favor, the non-whites, like all other diseases. Usually the non-whites, all the Hispanics, all the Arabs, all the, all the, the African Americans. This is, of course, talking about in context of the U.S., are more likely to have prostatic adenocarcinoma than the whites. I told you the white race is actually a protective factor. So this is something to definitely keep in mind. Now, what are the, other than race, what are the other, risk factor in this case? Other factors include androgen, as we have talked about, the most prominent, the most important, heredity, environmental factors, and the rest. So let's talk about them. Starting with androgen, central role. Remember that actually for adenocarcinoma of the prostate to develop, you need an intact, pituitary LH, axis. Okay, the LH is going to be actually the basis for all of this. Why? Because this is how the androgen is going to be made and released, right? And then that's going to be that's going to be converted into DHA, and DHA will take care of business on the prostate. So an intact, pituitary with an intact luteinizing hormone are a must for actually prostatic adenocarcinoma. Now, we have also evidence that one of the perks of castration is actually going to be that those men are not going to develop, are not going to be developing, prostatic adenocarcinoma. Now, a dependence of androgen is not going to be only limited to the development or the, the origin of the tumor, the how about the carcinogenesis of the prostatic tissue, but also to maintaining it, to maintain its growth and progression. And that has been also, cemented clinically. How? If you actually bring in a hormone that is the antidote of the androgen, in this case, as you know, is the most powerful hormone in the universe, the estrogen, and give it to someone with prostatic adenocarcinoma, what happened to those patients with the prostatic adenocarcinoma? What happened to their tumor? It shrinks, it regresses. Exactly, it regresses. So that's a very, what you call a clinical evidence that those cells are dependent, those tumor cells are dependent on their development and progression on the actually on the androgens. Now they do chemical cast. Do you know who they do chemical castration to in the U.S. as a crime, as a punishment of crime? Child rapist. We don't know to do that. Now, someone will come to you, those actually who have read so much into medicine will come to you, but tell you, doc, there are actually a group of prostatic adenocarcinoma patients who are resistant to anti-androgen treatment. How would you explain that? And, it was found out that the majority of those cases, have an activating mutation of their androgen receptors. How about that? So, that is going to keep firing into the nucleus on a perpetual basis, putting the prostatic, epithelium into a hyperdrive of division and creating prostatic adenocarcinoma in the absence of androgen. So if you think about it, both of them are androgen related. Do you agree with that? Okay. All right. So heredity, those actually patients who are first degree relatives, of patients who have prostatic adenocarcinoma have a higher chance of development of prostatic adenocarcinoma. Okay. So it was also found that the MYC oncogene, the proto-oncogene that turns into an oncogene, was found that, which is carried on chromosome 8 to be related to the increased incidence of prostatic adenocarcinoma in blacks. A similar kind of association was found in a locus on chromosome 1 in the white population. Of course, at a much less, prevalence of the disease. Environment, with the presence of all those, good stuff that we all eat, this fast food, things that we eat on a perpetual basis, right? When two parents are working or one parent is working and the second one is not working, but like to eat out, right? The rest is history. What is so bad in fast food, that may actually cause this to happen? Two words. Processed food, absolutely. But that's not, I want a pathology. I'm a pathologist, man. I don't know that, the lane word, huh? Not methylation. Two words. Free radicals. Free radicals. It's all free radicals, isn't it? What's a processing? When you say the word highly processed food, what does it mean? Give me a form of processing. No? No, it's as simple as fire, as simple as pressure. For example, if you look at, there are two actually forms of olive oil, right? There is olive oil that will tell you, first press, okay? And what else do they tell you? Organic, of course, but they will tell you first press and no processing, meaning it was not actually exposed to any heat, and it was not exposed to any pressure, or a little pressure actually that resulted in this. Example of this is what? Do you guys know? Let's see how much you know in nutrition. Example of this, olive oil. Example of this. What else? Avocado oil. Avocado oil. And example of this. Butter is a completely different thing, aren't you? Example of this is the coconut oil. So coconut, avocado, and olive are the best. Why they are the best? Because they are so loaded in the fruit that you don't really need to do much in order to extract the oil. How about seed oils? The other seed oils, corn and the rest. What do you do to them? You have to actually put them through a lot of actually pressure and heat to extract the oil. So as a result, and then you actually use them to do what? To do cooking, right? What does the cooking introduce in this? Even more free radical. So they are so fragile by the time you use, they are going to be loaded with free radicals. And you cook your food with them, right? So that's going to be, now you're going to get the steak or this actually, whatever, eggs or whatever you're eating, that's going to be loaded with the good stuff, right? And free radicals are the base of all, evil, right? What do free radicals do? Two things or three actually components they are so fond of, right? The membrane of the cell, the genome of the cell and the mitochondria of the cell. They go after the most important component of the cell and they wreck the cell, right, as a result of that. So, with the advent of the fast food around the world, it is now actually definitely on the rise. This is why prostatic adenocarcinoma is on the rise. Did we finish? 12? Okay, so we'll finish tomorrow. I don't really care anymore. For the girls, I cared a little bit. Why? Because I needed to tell you something about the tumors before the clinical guy. But the clinical guy already have given it to you. So obviously there is no. Did he give you prostatic carcinoma today? Okay, so there is no reason. We'll finish it tomorrow, inshallah. Okay? Yes, sir. For sure, absolutely. For a lot of tumors, not just this. All androgen-dependent tumors are going to be, affected. Androgen-dependent tissue are going to be affected with this. Yes, sir. Ala. I send you the stuff.
Yeah, and then from 11 to 12 for the females. Can we combine the lecture? And
My pleasure. Especially that I arrived in the same place like I did with the girl.
Better to
So what time?
11.
Perfect, man. You guys are godsend for sure. Thank you very much. الله يعافيك.
So I'll confirm with the
Please.
students.